into our presentation this morning. All right, so we are talking about everything MSK. We're going to talk about just some anatomy, and then these big joints and kind of some of the special tests that we need to know for our boards exam. And then we'll get into some things like fracture, really, really basic, right? We're not going to go super deep into everything, but we're going to just cover some different topics. We'll talk a little bit about gout. We'll talk a little bit about osteoarthritis, rheumatoid arthritis. And so without further ado, let's dive right in. I'm going to start with the knee joint. Okay, this is a big one. Let's just review our anatomy really quickly. So that knee joint is primarily formed by our femur, the thigh bone, right? And then the tibia, the shin bone, and overlaying that is the patella or the kneecap. These bones are going to articulate with one another to create that hinge joint, which enables our flexion and then our extension. All right. Most important thing that we think about here with the knee is all those ligaments that kind of keep it attached so that we can continue to walk. And you hear about these injuries all the time, especially in athletes. So first, we're going to talk about that anterior cruciate ligament, which is the ACL. That guy runs diagonally in the center of the knee, sorry, and it prevents that excessive forward movement of the tibia in relationship to the femur. So femur comes here, tibia comes here. We want to make sure that we don't have any forward movement, and then also rotational movements. Okay, the posterior cruciate ligament is right behind it and runs kind of opposite, kind of creates that X. So we have our anterior, and then behind it, our posterior. And that guy is going to limit the movement of the tibia backwards in relationship to that femur. Okay, and that provides stability and hyperextension. Then we have our MCL and our LCL. Okay, medial collateral ligament can be found along the inner side of the knee. And that guy, so if this is the inner side of our knee, this is our MCL, he is, or she, whatever, that ligament is going to really resist forces of the knee going inward. So it provides stability against that valgus stress. So I'll give you a little pro tip here in a minute, but what we're thinking about here is the MCL here, and then our LCLs on the outside of our knee. And that guy is here that resists force coming from the inward part and pushing our knee outwards. Okay, against varus stress. So we have our patellar ligaments that helps keep the patella in place. We have our popliteal ligaments along the back of the knee. Also contain our knee, we also have the menisci, so that medial and lateral meniscus, which are those crescent-shaped cartilages located between the femoral condyles and the tibia plateau. They're kind of our shock absorbers, I think about kind of those pillows in our knees. They distribute our load and then also work in some joint stability. Um, then we have a further shock absorption. We have that synovial membrane that produces the synovial fluid, which lubricates that joint, allows that movement, reduces friction between all of those moving parts that are happening, also provides a lot of the nourishment to our cartilage. All right, so our cartilage lives over our bone endings there, and in order to keep it healthy, we need that synovial fluid there. Okay, anterior cruciate ligament is going to be our first one. We consider the anterior drawer test or the Lockman test. That's our special test to check the laxity or the integrity of that ligament. So, what we're thinking about here and how do we perform it? I always start on the good knee first, and I'm going to compare side to side. That tells me what is this patient's baseline? Is this patient have really, really tight ligaments? Or are they kind of loose and, they're pretty flimsy and you can really pull? And that gives us an idea. So we do the good leg first and then we move to the bad leg. Also kind of prepares our patient for what we're going to do when they have an injured area of their body. But what you're going to do, have them lay supine, and you're going to go ahead and bring that leg up on the table, like you can see here in the photo. You can see this guy's kind of sitting on the toes. That's also a great way to do it, to kind of hold that leg in place. And all you're doing is you're going to pull the tibia forward. I actually stabilize that femur with one hand, and then I pull with the other. You can see this guy's just pulling straight forward. What you're looking for is a clunk, which is the ACL engaging at the end of that movement. Okay, so when you check the good side and you're gonna pull forward, and a lock is gonna kind of happen, an end clunk at the end of that pulling forward, and that tells you that ACL is nicely intact. Now, if you have a completely torn ACL, what you're going to find is just a little bit more laxity, and you're going to lack that kind of end clunking sound when you're pulling forward or that anterior movement. So, just like you're pulling out a drawer, you're pulling out that tibia, because remember, the ACL is really important in maintaining that and not have too much forward movement of the tibia in relationship to that femur. And so if that ligament, which comes right across here, is no longer engaged, is torn apart, kind of have a little nub in there, then you're going to have more laxity in the ability to pull that tibia forward. All right. We call that also the Lockman test. So what you're looking for, joint or sorry, ligament laxity or integrity. Okay, so just a quick pro tip mnemonic here. So valgus and varus is something that we can apply those terms anywhere. And all it's telling us is about where pressure is being applied to. Okay. So you might have valgus knees or ankles, feet kind of coming inwards or going outwards. And so what we think about when I think of valgus, I think gum. Gum is sticky and it's going to make things stick together. So that's going to be your external force making your knees kind of come together. And so valgus sticking together gum. Okay. And then varus is just the opposite. Varus is kind of going out. So that's more of your bowed knees, or that's pressure applying outward force. Okay. And that's important because when we talk about the lateral and medial ligaments, we're going to use test names called valgus. All right. So that's that coming together. And what you're checking for here is medial laxity. Okay. Or medial ligament integrity here. So when you're applying outward pressure, that's the valgus stress test. But what you're testing for is that medial collateral ligament integrity versus the varus stress test. So I'm going to apply external force. I'm pushing that knee away from the other knee. Okay. And that's varus stress. And what we're testing there is the laxity of our lateral collateral ligament, or the LCL. Okay. So think about when you're sitting there and you're taking your test, think about your anatomy. Think about the valgus, valgum sticking together. So you're applying force, trying to get those knees to stick together like gum. And what you're testing for is that joint that or that ligament that you're putting stress on, right? So you're when you're pushing from the outside, you're putting stress on that medial collateral ligament. And if you're putting stress on the inside of the knee, you're stressing actually the lateral side. So think through that process every time. Take your time if you see this test question come up to really think about what is it? Where am I applying the stress and what is it that I'm testing? Because you can get those two kind of confused. Okay, then we also have a test for our meniscus. McMurray Meniscus Test. Okay, what we're doing here is we're trying to elicit like a click or a pop or pain while we're kind of grinding on that meniscus. Okay, so what you're going to do is you have the foot up at that 90 degrees, and while you're straightening or extending the leg, you're twisting and turning that meniscus, kind of grinding that meniscus and seeing if you can elicit some sort of positive sign, which would be a click, a pop, or some pain when you're extending and twisting and turning of that foot. Okay. The other way you can do this is what I typically do because it's really hard if you have a really heavy leg. I'm a smaller person, and if it's a heavy, heavy leg and you're trying to do this and get it, it can be a little tough. So, what I do is I have my patient stand up, go to bend down. Only on first we do the good leg, then we do the bad leg. So the first leg, and then what they're going to do is they're actually going to twist and turn while their knee is bent, and they only have pressure on that one foot. Okay, all of their weight's kind of shifted over there, and they're twisting and turning, and you can see that we're mimicking that same thing. And if that hurts, if any of these special tests hurt, it gives us an inclination that something might be going on. So the McMurray's test, it tells us maybe there's something wrong with the meniscus. The anterior drawer is telling us a little bit about that. The ACL, and then our varus and valgus are telling us about those lateral and medial ligaments. Okay, so they're not 100%, right? If we get these positive tests, doesn't mean that there is actually a tear there, but it gives us information that maybe we should do something else. The next step, oftentimes, is going to be ordering imaging and maybe physical therapy, depending on what your insurance is. But typically, the best way to look and find some sort of soft tissue injury is going to be through an MRI. And you might say, I'm pretty sure you have something torn in here, and you may be able to get insurance to go ahead and approve an MRI right off the bat based on what your findings are and how you document. Um, but it may be required for certain insurances that there's an X-ray performed as well as physical therapy completed. So you're going to have to kind of live within those realms, but knowing for tests, in order to find a soft tissue injury, we're going to need to order an MRI. All right. So moving on now, we have what's called our Baker's cyst. This is a super, super common phenomenon that you're going to see if you're working in the primary care or sports medicine arena. What a Baker's cyst is, it's a fluid-filled sac behind the knee. So we know that if there is some fluid, you can palpate it behind the knee. You have a little bit of a fat pad back there, so you'd have to be able to compare side to side, right? So you're looking at the good knee and then the bad knee, unless they both have it, which is possible. But what you're going to see is that it just looks more inflamed and that there's like a palpable kind of movement as you're feeling and palpating back there. You can visualize it as well. But what your brain should think about with a Baker's cyst is inflammation. So you think of the knee joint as kind of like a Ziploc bag. Now we have all that synovial fluid in there. And for some reason, I often think of arthritis or runners who are putting lots and lots of pressure on those joints. Maybe you're getting some bone to bone, those bones are getting inflamed. They're releasing a lot of immune response now. We have our Ziploc bag that's getting bigger. And where's that fluid going to go? It's going to go behind the knee, and that is your Baker's cyst. All right. Oftentimes we can diagnose this just by kind of looking at it. Okay. And then we can say, hey, rest, get rid of, take away whatever it is that you're doing that's causing some of that pain if possible. So oftentimes I think of these in runners, slow down your mileage a little bit, let your body heal, maybe really focus on strengthening your hamstrings and your quads and making sure that your legs are super, super strong. Your glutes are super strong to support that knee if you're going to continue running. So you can't just be a runner, you need to incorporate some resistance and strength training. Um, if you have some other concerns, ultrasound and MRIs are not wrong. And typically they just go away on their own. However, there are surgeries that we can do to drain or remove the cyst. But oftentimes they'll just kind of come back if we don't fix what's going on and causing that problem in the beginning. Again, I think of arthritis as kind of something that's causing it. All right, we're going to move down the leg into ankle sprains. All right, ankle sprains are pretty simple to go ahead and diagnose. What we're looking for is laxity in that ankle because we think of ligament injury. Oftentimes, we're having an inversion type of injury. So somebody steps off the curve incorrectly, maybe steps on the soccer ball incorrectly. And what the ankle wants to do most of the time is over invert. Okay. And so when you're if you think about the ankle and it slips inwards, what's really being injured oftentimes is that lateral ligament area. Okay. And so here's your foot, it comes in. Now you've put way too much stress on that ligament. Ouch, ouch, ouch. It hurts. And then we grade them based on that. You can have an everted injury where you would have more of that medial ligament injury happening, depending on how the foot turned and what the pressure was. So always asking about the mechanism of injury. And sometimes I even get up and I kind of mimic it. Is this what happened when you fell? Is this what happened to your foot? Do you remember how that felt? Same with your knees, same with your shoulders. Trying to mimic exactly what happened can give us a lot of information about what we think might have gone wrong. And for me, I'm such a visual person. If I stand up and I say, okay, this is what I understand happened, does that look right? And then I think through my anatomy and I think through exactly where that pressure and stress is happening. It allows me to understand what ligaments, what soft tissue, maybe bones might be at risk for injury during that movement, right? Um, Back to our ankle sprains, sorry, a little tangent there. Back to our ankle sprains, we think of grades one, two, and three. All right, grade one, that's our mildest ankle sprain. This is somebody who, not too bad, maybe just a little bit, but they can still bear weight on that foot. Might have a little bit of bruising, maybe a little tenderness, swelling. But when you go to check that joint from good side to bad side, we're not seeing too much laxity or instability in that ankle. All right, but then we step it up a notch. We go to grade two. Here we're actually seeing a partial tear. So if we got an MRI on this guy, you would see that that ligament does have some tearing happening, but it's still intact. Okay, this is going to be a little bit more painful, a little bit more bruising, a little more tender, a little more swelling happening. And when we go ahead and we check the stability of that joint, we're going to find that it's a little more lax. Okay, we have a little bit more give when we're doing our inversion eversion of that ankle, and this person doesn't really want to bear weight, but they can if needed. Moving up to grade three, now we're thinking much more intense, more serious. Okay. When we do an MRI of this ankle, we see that that ligament is completely torn. We may even see an avulsion fracture of that malleolus wherever it was connected to and how severe it was. I think of grade three ankle sprains as so incredibly terrible, really long recovery. Oh, not great. So when we have a ligament tear, that ligament is connecting bone to bone. And what can actually occur is if there's enough force from the injury or from the stress that was applied. So if you had some traumatic event, what can happen is a piece of the bone actually comes off when the ligament tears, and that is called an avulsion fracture along with a ligament tear. And those are pretty common. So you always have to kind of think about that. You can see that the tibia plateau when we were talking about ACLs, that's kind of a common injury that also happens. If that ACL is blown off with a lot of stress and force, you can get a piece of the tibia plateau that comes with it. So a piece of that bone. All right. With the grade threes here, we're seeing lots of instability. And this person, despite their best efforts, they're not going to put weight on that ankle. Okay. MRI, X-ray, we're looking for some severe stuff here. All right. Now, when do we order those x-rays? When we have somebody coming in with an ankle injury, you might be asking yourself, well, when do I get an x-ray? How do I know if it's just a sprain versus some sort of fracture happening in that area? Well, luckily, we have these things called the Ottawa rules. I use them all the time. I pull them up in the patient room oftentimes because I can't always remember exactly which ones. And so I use my resources. It's important you as nurse practitioners use your resources. Don't be afraid to look things up and continue to do that. I've been in practice 5 years now, and I see an ankle sprain maybe every few months, right? And so I have to go in and like reassess, okay, exactly where am I looking for these bony tenderness? That's what our Ottawa rules tell us. We're looking for bony tenderness in these specific areas. So we're looking at the posterior edge of the tip of the tibia or the tip of the medial malleolus. So kind of on both sides of that ankle here, we're looking for bony tenderness. So you go ahead and you touch that area. All right. I do it on the good side first, and so I can tell my patient this is what I'm going to be doing. I'm looking for tenderness when I touch this bone, not necessarily the ligaments, which is everything's going to be a little tender in there, right? But when I put my finger on those malleolus, does it hurt? I'm also looking at the base of the fifth metatarsal. Okay, so right down there off the pinky, and then the navicular bone. So the navicular is the one I always have to look up, but it's on that medial side. Right below there. So I don't have a great picture of it, but look it up. Red flags, sometimes when you'll always order imaging, if somebody can't bear weight, make sure you're getting an x-ray, okay? And if they're over 55 years of age, we'll get an x-ray for those folks as well because of the risk of injury and just kind of bone weakening that can happen. All right. As a nurse practitioner, when you're new, starting out, you're going to order more x-rays than you probably will as you get more experience. That's okay. Take your time, but really think through these things. If there's a ton of swelling, you might wait for that swelling to go down just a little bit, maybe put them on crutches, go ahead and secure the joint and just say, let's get an x-ray in a couple of days, depending on your level of concern. Okay. And what you think's going on. Because what can happen is if there's a ton of swelling, it can actually obscure some sort of a fracture happening in that area. So sometimes it's good to just wait a couple of days. One patient that I had, she got her x-ray a couple of days after the injury, came back 10 days later. The x-ray was normal, came back and she was like, I think it's worse. I think my pain is worse. And she had that at this point coming back in, she had not taken my advice and kind of taken it easy. She was a librarian. She walked a bunch and what could have been just like a hairline fracture that was missed in that early x-ray on that second. So I did a repeat x-ray because now I have like a lot of metatarsal tenderness for her. And when I got that repeat x-ray, it actually showed a full fracture at that point. So not taking it easy, not taking that break, and then maybe the swelling was obscuring something that was there that we missed. Anyway, she ended up getting into a boot, and like a hard soled boot, and was in there and she was fine after about 8 weeks of maybe 6 weeks. I can't remember exactly the details, but ortho took over and she was in a boot and everything healed up really nicely. But just saying, if you need to, you can repeat an x-ray if you have concern. And maybe that first x-ray obscured something because of the swelling. Okay, audible rules for your exam though, okay? And good in practice. Other fractures that we think about the Coles fracture. That's the broken radius. Okay, so radial pulse. Where do you take your radial pulse? That's how I remember what the radius is there. This is that Fouche injury. So when I think about a Fouche injury, it stands for fall out on a outstretched hand. Right now it's icy in Denver. We had some snow. So I think of people who are maybe out walking and they slip on the ice. And what is your reaction? It is to put your arms out in front and bam, you hit it. And now you have this nice fracture right in that radial, and usually in that distal radius. Um, if it extends into the joint, that is something that requires more advanced care. But we'd go ahead, get our x-ray, splint the affected joint, and figure out, how extensive the fracture is. Do we need ortho's involvement? Hip fractures, something super, super common in our older population. I always have conversations about not having slip rags, wearing shoes in the house because it can help guide your feet a little bit to prevent a fall. And then lighting at night. A lot of these hip fractures occur, somebody kind of trips over just a small rug, or it's dark, they're getting out of bed, maybe they're rushing to go to the restroom, and they slip and fall and break a hip. These are very, very devastating for certain patients. It can lead to infection, that muscle atrophy, you're bedridden. And then when we're bedridden, we think of pressure injuries. So we want to prevent these things. We have that get up and go. How long does it take your patient to get out of a chair? And then just working on strength training and stuff like that with your older population to prevent hip fractures. Pelvic fractures, these guys are medical emergencies. And the reason being is because of all the blood that runs through the pelvis, okay, all those main arteries that are going down there, we think about risk of bleeding and infection. This is something you may see after a motor vehicle accident or a really significant fall from a high, um, like a high footage. Okay, so if somebody's up pretty high, they fall off a roof or something, and we have a pelvic fracture. If there's any suspicion, if you're like first on a scene somehow, a neighbor or something like that, this is a medical emergency. We're going to get them to the emergency room right away. All right, pull out your phones, guys. I have a practice question for you. The question is, a positive anterior drawer test is suspicious for laxity of which ligament? That anterior drawer. Do you all remember that? I'm going to pull it up here. Sorry, I just got to go to the next one. All right, it should be active. I'm going to check my phone, just make sure it's working. And yes, it is. All right. If you have a moment, pull your phones back out. Take a look here. And let's see, what do people think when we think of that anterior drawer test? So laxity in the anterior drawer. Is anterior drawer test looking at the ACL, the MCL, the PCL, or the meniscus? All right, we've got one person who said the ACL. Awesome. Thank you. Anybody else? What do you think? The anterior drawer. Sorry, I'll go back to our question real quick so you can look at the question. Is it A, B, C, or D for laxity in that anterior drawer test? All right, we've got two people who say the ACL. Awesome. And if you got out, you can just rescan to get back in here. I'm going to take a sip of coffee. Great, guys. Okay, it is the ACL. Remember, anterior drawer, ACL, that's how to remember it. Anterior, anterior, right? We're pulling on that. We're looking for that clunk as we pull on the tibia. Really, really good. Okay, sorry. Back over here. And yes, it is the anterior cruciate ligament. Okay. Any questions with that, you can put them in the chat with Rachel. She'll help you. Next, we're going to move to our shoulder. So we think about the rotator cuff, guys. This is a really, really common injury. Can be chronic or acute depending on the mechanism. So I had one woman, she was probably 65, 70 years old, had some chronic pain. We did end up getting an MRI and it showed a chronic injury. And her job was cutting palm or she was cutting palm a lot. And so it's a lot of this movement over and over and over for years and years and years, chronic rotator cuff injury. My brother, bike accident, he took a turn really, really fast out on a mountain bike trail, fell, hit it, and had a complete tear of the supraspinatus. All right, that's a really common one. So when I think about the rotator cuff, I like the acronym SITS. So we think of supraspinatus, SITS, okay? Supraspinatus, infraspinatus, teres minor, and the subscapularis. The supraspinatus is located right on top of that shoulder blade that initiates the abduction or lifting away from the body and really helps stabilize our shoulder joint. Then we have our infraspinatus, which comes in and really helps that external rotation of our shoulder joint. Okay, so external rotation, we're moving away and contributes to the joint stability there. The teres minor sits below that infraspinatus, comes around the lateral border. Um, of the scapula and helps again with that external rotation and stability. And then finally, that subscapularis, which is located on the anterior surface of that scapula and the subscapular fossa. It's responsible for internal rotation of that shoulder, so coming inwards. And then we just think of all these guys really working together to stabilize the humeral head within the glenoid cavity. Okay, so that's what our rotator cuff does. It allows us to have all of this range of motion and continue to have strength. Okay, we can test these with some of our special tests. We think of impingement using what is called the painful arc test. So if you think about this guy, you're thinking about some pressure that is being caused around that AC joint. And so what we do is we have the patient, again, good arm first, go ahead, no pain, and you just show them what you're having them do is just kind of like they're reaching up over their head. And what a positive painful arc test is going to be pain when we are putting the most pressure on that the subacromial area. So if you think about it, when we get to about 60 to 120 degrees, we're going to have a lot of pain. So no pain. So we have them bring it up, no pain, no pain, no pain. Here we're experiencing starting of pain, 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 and then it goes away. And what that considers is that there's some sort of impingement happening in that area. And we think of this as the painful arc test. That's a positive. What we can do, depending on your level of concern and what else is happening in the mechanism of injury, we may consider something like PT or home exercises. Okay, if you have that, you could start there depending, or an MRI. All right. Then we go to our Job or the empty can test. We can also call this the supraspinatus test. What we're looking for here is that supraspinatus tendon rotator cuff, which is the most common area to have that rotator cuff injury. So what we do here is we have the patient sit or stand, but what they're going to do is they're going to go ahead and raise their arms to about 90 degrees. They're going to not be right in front. They're going to actually come out to this side just a little bit. Go ahead, point their thumbs downwards. While they're doing this, you're going to apply resistance by pushing down on both arms, and they're going to try to maintain that position. So you're going to say, just don't let me move your arms, okay? And if somebody has some laxity or some compromise to that supraspinatus tendon, what you're going to find is pain and weakness in comparison to the other. Now, if they have it in both shoulders and they just can't resist you in either, and you're like, wow, I really think you should be stronger than this, then you can go ahead and have suspicion. But typically, if it's like an acute injury, it's going to be in just one side, and you're going to notice, okay, in that right side, They just can't maintain when I'm putting that pressure. Okay, moving onwards, we have epicondilitis. We can have medial, all right, or lateral. When you're thinking about this, this is super, super common. I think of this as kind of an overuse injury. What were you doing recently when this kind of started, or what do you do for work or for hobbies, right? If you have somebody who's, went out and golfed 18 holes, they haven't golfed in a long time, and now all of a sudden they're experiencing a lot of pain and tenderness on that medial aspect of the elbow, I would consider that medial epicondylitis or golfer's elbow. So we have pain, tenderness. You might even get a little bit of like what is the word, vibration, kind of as that tendon is moving. So when they move their elbow and that tendon is super, super inflamed and it's not tracking through those grooves, it's kind of like coming around. And then when they're doing that, any sort of movement that requires tension on that tendon, what you're getting is a little bit of that vibration as that swollen tendon is trying to move through those nice bone grooves. Okay. Um, you see this quite a bit. This is something that you could consider a joint injection or a steroid injection into that tendon. You can get trained on this as a nurse practitioner. You want to make sure you really understand your anatomy before you're going in and have really, really good training. Um, Doing some time with an orthopedist is not a bad idea if you want to implement this into your daily routine or somebody who does this a lot. So if you work in a clinic and you have somebody who's like, I feel really confident in training you on this, go for it. I think it's a great way to kind of break up your day as an NP. And that's something we can do within our scope, I think, in most states, but check with your state. Um, so we diagnose this oftentimes just on exam and history. Okay, we can consider getting X-ray, MRI if we're really worried, but the treatment is really going to be just rest. You could do some NSAIDs to get some of that inflammation down, physical therapy, and making sure all of the other, the muscles around are nice and strong. And then again, that steroid injection. Lateral, we're just thinking a little bit just on the outside of the elbow now. And if you think of somebody serving a tennis ball, and you think about what muscle is engaged there, and then you think of the tendon that runs all the way up there, you're going to see the exact same thing. We're thinking of some some tendonitis in that area in relation to probably some overuse. Okay. We can do steroid injections there again, and NSAIDs, physical therapy, depending on what you're seeing. But ask about the mechanism of injury and what they're doing. And if you need to, go ahead. Okay, if I'm golfing, what am I using? If I'm playing tennis, what am I using to remember how these things work when you're sitting in your exam? Okay, carpal tunnel, super common again. And what we think about here is compression of that median nerve. So we have our ulnar nerve and our medial nerve that go through there. Our medial nerve comes right under the carpal tunnel. It innervates our thumb, our forefinger, middle finger, and half of the ring or the fourth digit. Okay, so half here. And what people experience oftentimes with carpal tunnel syndrome is some numbness and tingling. It can actually go up the arm as well and come both ways. Oftentimes they're going to say, like, I wake up with numb hands. And the reason being that we think is actually when somebody is asleep, what they're doing is they're kind of collapsing their hand down and they're putting pressure on that medial nerve. Maybe they have some swelling and inflammation already there from typing all day, and then they go to sleep and they kind of collapse that down. They're putting pressure. Now we have some compromised blood flow to that nerve. That nerve is angry, not super happy. And what does it do? It signals like, hey, wake up. This isn't good. And then you go to that neutral position and it's kind of gone. Um, we are going to try to elicit those symptoms when we're testing for this and trying to understand what's going on with our patient. The different tests that we have Phelan's and Tinel's, which are the most common. I use this all the time. I do mostly Phelan's test. And what that is, I think of, okay, so think of like Phelan's P and think of prayer, like how you would hold your hands in a prayer. And Phelan's, I think of a backwards prayer. So what you're going to do is take the hands and actually have them go face to face and then bring the elbows down to about 90 degrees or as close close as we can. And when you're in this, you're putting a lot of pressure on that medial nerve. What happens there is that the hand starts to kind of fall asleep. You get that numbness and tingling. I have some right now, definitely in that right hand. And that is your positive sign. Okay. You hold it there for about a minute or two. And I always do it with my patient because, like, okay, I'm starting to experience it. Are you feeling anything there? And if they are, it's a good indication that they probably have a little bit of carpal tunnel syndrome going on. We do want to do something about this, okay? We don't want to just ignore it because what can happen if we ignore carpal tunnel is that we get atrophy to those areas. So that nerve is going to have some irreversible damage happening if we don't do something, if it's severe. And then when we have nerve damage, then we get muscle atrophy, and then we start to lose the function of our hands. That would be an advanced case. Hopefully, somebody's coming in sooner than that and they're getting treatment. Treatment early on can be something like some NSAIDs and then night splinting or splinting during like things like typing. Um, During those repetitive movements that somebody might be doing throughout the day. Severe cases, if you're starting to see some muscle atrophy, I see it right down here first. I would get those guys into a hand specialist. They may go in and actually release that carpal tunnel, allowing that nerve to kind of expand and prevent worsening. We see an increase of this during pregnancy. So, if somebody is experiencing it and it's just, they're pregnant and they haven't really had it before, you can get away with just night splinting. You can buy it at Walgreens, Target, and you just want to make sure they have that metal piece in there. And then it just keeps the hands in that neutral position during sleep time when we have a lot of that kind of bending. You're getting into your fetal position. You're kind of, cozying up or whatever. Obesity is also a risk factor here. Okay, moving on. Osteoarthritis. I worked with an orthopedist and he said to, I think almost every patient who came in and had arthritis going on, he said, you have 60,000 miles or 65 years, whichever comes first. So depending on how hard you are on your joints, we're going to see some degeneration that happens, okay? Oftentimes in the knees, but if you're a baseball player or you do a lot of work with your arms, you may see this in the shoulder, you could see it in the hips, ankles, just depending on what you're doing throughout your life, how hard you are. If you're a runner, might see a little bit of joint degeneration in those knees, kind of a little bit earlier on, okay? Risk factors seem to be female, but it does happen in both males and females. Obesity, just think of weight and what stress we're putting on those joints, what we're asking those joints to do. Are we asking those joints to carry around 400 pounds? They're gonna get degenerated sooner. Again, overuse or trauma. So if you've had a bunch of surgeries, if you were that athlete that tore your ACL 3 times, any sort of trauma to the knee and surgical trauma as well can cause an early degeneration of that cartilage that really helps protect our bones. Family history seems to be something there. And then just age as you get older, like I said, that 65-year mark, right? Depending on how hard you are on those joints, what happens is that nice cartilage that covers that tibia, or sorry, the femur and the tibia plateau, over time, that cartilage just kind of degenerates, and then we get bone on bone. So you'll see joint space narrowing when you get an X-ray on these guys, and that is really how we're going to diagnose this. On X-ray, there's joint space narrowing. You can have tricompartmental. That means in every area of the knee, we're seeing that there's less of that cartilage present. And when bones hit bones, as we know, they start to swell up. Then you get these effusions. You can do some of your tests there, seeing that there's effusions especially on a knee exam. Is going to tell us that we think there's some sort of arthritis happening. All right. So to differentiate osteo versus rheumatoid, I think often about these symptoms. Okay. So osteoarthritis, typically the joint over time is just kind of getting more and more uncomfortable. Okay. Years of discomfort gets to the point where somebody's coming in and starting to say like, oh yeah, it really hurts. All right, one-sided, typically, and maybe it's just the knees. Maybe you have arthritis in both knees. You might just have it in the right knee. Hard to say, but we like to think of not so much of all the joints, okay? the pain, when you first get up in the morning, it's a little bit creaky, but you start kind of moving and things get better. So it gets better within about 30 minutes of waking up. And then if you had a really busy day, if you went and walked Disneyland with your grandkids or something, then your joints get really, really sore. Okay. So the more active you are, that evening kind of starts to hurt. We do see a reduced range of motion due to that inflammation that's happening. In the hands, we see the Bouchard's or Hebertin nodes that occur with osteoarthritis. Okay, again, age-related degeneration is what I like to think about when I'm thinking of osteoarthritis. Diagnosis on exam, also X-ray treatment. NSAIDs, but careful, right? We have an older population here. We're not going to hit them super hard with ibuprofen all the time because of the risk of a GI bleed or something like that. Acetaminophen can be helpful. Steroid injections, yes, maybe no. Um, we're doing that hyaluronic acid, that gel injection, which can be pretty helpful for people. We also have complete joint replacements, right? Knee replacements, hip replacements, shoulder replacements. Those things all do help quite a bit. PT, super, super beneficial, guys. I try to get everybody to make sure that their glutes, that their quads and their hamstrings, especially for knees, I just think about knees a lot because we see it so commonly. I want to make sure that all those supportive muscles are super, super strong. So we're trying to alleviate as much load on those knees as possible. Okay, working on weight if weight is an issue. Um, are they a candidate for a GLP-1 receptor agonist? Could we give them a little bit of something to help get their weight down? Do we need to refer them off to obesity medicine? For some help with their weight? Those things need to be something at the forefront of your mind, okay? Moving on, now we're going to talk about rheumatoid arthritis. So, rheumatoid arthritis is different from our osteoarthritis, and this is a autoimmune condition. The body is attacking that synovial joint, causing inflammation in there, maybe causing problems elsewhere in the body as well. I think of the kidneys, lungs, other types of problems with an autoimmune disease. All right, so risk factors here. We do see that obesity in female, again, genetics, smoking seem to all be kind of coming together. I think of family history of any sort of autoimmune disease kind of puts them at risk of a different type of autoimmune disease. There's kind of a lot of these autoimmune diseases live kind of in that same class of diseases. We just don't know which one you're going to get, right? You could have lupus or rheumatoid, but oftentimes that we think of Sjogren's, all that kind of lives in that same class, and we think about these things similarly, and their diagnosis also kind of similarly, or their workup, sorry. Symptoms here, we think like this kind of comes on quickly, whereas in our osteoarthritis, it was kind of over years, right? Years of joint degeneration and losing that cartilage. Where here, these people, I'm going to tell you a patient, she was 6 months postpartum, maybe 32 years old. Mother had lupus, sister had thyroid disease. She came in and said, I just feel like I am so stiff and all of my joints hurt. Okay. It doesn't go away. The stiffness kind of lasts all day. Maybe it gets a little bit better with a little motion, but it's still pretty present. Here we see that swan neck deformity or the boutonniere deformity in the hands. Those are the people who you can really, really notice that versus just the big Hebertin and Hebertin nodes that we see in osteo. All right, so when we're thinking about this, like with her, the first thing I did was go ahead and get some panels, right? I was already thinking, oh goodness, she just had a baby, which seems to change the immune system a little bit, kind of can turn on some of those genes, which in her case, unfortunately, it did. She came back with a positive RF and her CRP. So that inflammatory marker, ESR and CRP are inflammatory markers. They're non-specific, but they're a great way to start to understand, is there an autoimmune condition happening? Is there an inflammatory response happening in the body? And if those are elevated, it can lead you down the path of which way you're going to go. Okay, we use those in any sort of um, we use those labs, the ESR and the CRP, if we're suspicious of inflammation happening in the body. It's not specific to something just like rheumatoid arthritis, okay? It just means there's an inflammatory process occurring. Okay, rheumatoid factor is more specific to our rheumatoid arthritis. We'll also go ahead and get an ANA and the anti-CCP. Here, we're just looking at the whole panel of rheumatoid conditions. Okay, in this case, we went ahead and started a little bit of prednisone to kind of get her pain under control while we waited for her to get in to see a rheumatologist. She is now very stable on a DMARD. She was trying to avoid any sort of immunologics type medication, but unfortunately needed it, and now is doing super well. But that's kind of that patient that I think about. However, this can happen in males. It can happen in older males, less common, but not a rule out. Okay. So you really want to understand what is their symptoms, what are they presenting with. X-ray can help determine, is it joint space narrowing? Is it more osteoarthritis? Because you will see that joint space narrowing here on that and that osteoarthritis versus a lab is going to, osteoarthritis shouldn't cause any sort of inflammation like the CRP shouldn't be super, super elevated. The RF would be negative. Okay. And that's a way to kind of differentiate if you're suspicious and you don't quite know. And as a new NP, it might be hard. So use those things, your x-rays and your labs, to kind of understand in addition to your history taking. Okay, gout. Gout, super common. Again, you're going to see this in the primary care setting. I think of males, but it can happen in females as well. Diet high in purine is what they think. So fish, cured meats tend to kind of cause those flares. So somebody says, I was at a barbecue yesterday, and then I woke up and my big toe is super swollen, red, hot to the touch. Could be in the knee, could be in the shoulder. But we think of those toes as being kind of that like hallmark sign. But what can happen is it kind of comes and goes. So the person might actually be self-managing because they just take some ibuprofen, which is kind of the treatment for gout, is a high dose NSAID to get that inflammation down. Now they're at the barbecue, they had a bunch of meat, they also had a few beers along with it. Maybe they're overweight, maybe they have some high blood pressure, maybe they're on a medication that kind of increases that uric acid level. And all of those risk factors come together to create what we consider gout. All right. So we would see swollen joints, red, hot to the touch type thing. Tophi would be actual like development of those uric acid crystals in that. You can palpate the tophi, you can see the tophi. I had one patient who has really huge tophi on his elbows. Um, and look that up if you're unfamiliar, because you should be able to see that on a patient and recognize essentially what it is right away. Diagnosis, again, asking the questions. We know this. Our questions and our ability to ask the right types of questions are going to help us get to the diagnosis a lot quicker. You may have a poor historian as a patient who just really doesn't give great answers. However, keep asking questions and really, really know what are the questions that you need to be asking to get to your diagnosis. We confirm this with a joint aspiration. However, we're not always going to be able to get a joint aspiration. So you may have to rely on their history and labs that you can get in the primary care setting, which would be like uric acid levels. It might not always be high. If they're not in a current flare, you might not see that elevated. Again, inflammation, we have an inflammatory response happening. So that ESR-CRP might be high. You can get an x-ray to rule out anything else. And our treatment here is to make some dietary lifestyle changes. Can we just avoid some of these meats and the alcohol and all these things that kind of seem to increase it? And in an acute TAC, we can prescribe something like indomethacin or colchicine. Some people use cortisone or like prednisone, depending on how bad the flare is. And then we think about how often they're having a flare and do we need to start preventing these? So if they're having flares multiple times a year, despite all of our best intentions, I would go ahead and consider some allopurinol. As a mechanism, but I'm also going to review their med list. Is there something I'm prescribing that could be causing this? I think of that hydrochlorothiazide always as something that could be causing something like gout, but there's a list of medications that do that. Okay, moving on, bursitis. We have about 5 minutes left, guys. Bursitis is just overuse. I think of bursitis anywhere where we have a bursa. It's just that fluid-filled area that kind of protects a bone. Elbows, knees, really common. Hip bursitis is also something common. We think of overuse. I think in school they told us like the example they gave me for bursitis is maybe somebody who cleans and they're down on their knees and they are scrubbing the floors, okay, and they have pressure. They're putting their knees on a hard surface. They wake up the next day and boy, oh boy, front of the knee is super swollen and painful. Um, we think, and tenderness, you can see it. We would go ahead, get an x-ray, an exam. And what you're going to do is just pretty much have them rest. You can consider PT, um, especially for like hip bursitis. Is there something that's not sliding right or something that's really kind of bothering that hip bursa that we need to be concerned about? And then NSAIDs. All right. They can go in and inject them and stuff like that. Not as common anymore. But if you're at a point where you're like, I'm not sure how to manage this patient, you can send them to ortho for that. Okay. Septic bursitis is now something more severe. This is when we're concerned about infection in that bursa. So do we have any sort of cut or opening that could increase the risk of this? Here, we're going to see a little bit more systemic symptoms going along with that. This is an emergency. We need to do something about this. We're going to get antibiotics on board right away, and make sure. So Staph aureus is kind of our most common. That can be a normal flora on our skin. But then once we get some sort of trauma or injury, now we've allowed that normal flora to get in where it shouldn't be, and it causes an infection. All right, want to do something because that infection can get deeper into our bodies and cause something like sepsis or osteomyelitis or something like that. So we do want to make sure we're recognizing that. Again, more systemic, more just severe than just your typical bursitis presentation. All right, we're going to do a quick case study. I have 3 minutes to get through this. So we have a 48-year-old. Pull out your phones for me because we're going to answer in here. So go ahead and get your phones out. So we have a 48-year-old male patient, history of hypertension, obesity, hyperlipidemia, and pre-diabetes. All right, he's taking lisinopril hydrochlorothiazide. He's also on semaglutide, 2 milligrams weekly, rosuvastatin, ibuprofen as needed. All right, he comes in. He is telling us his right ankle and left knee. This is actually a patient of mine. Intermittent flare-ups, currently treating this with some ibuprofen, 800 milligrams probably 3 times a day with some relief. And then it goes away and then it comes back. He's had this maybe 4 times in the past year. He's a new patient coming into you, see if you can help him out. He's been going to urgent cares for this, but no real diagnosis. And he reports some difficulty bearing weight with it. Just kind of hurts pretty bad. No history of injury, trauma. And when you look at him, you see some edema, warmth, redness, no laxity. Let's say it's just in the ankle today. What is your differential? I want to hear all of the different diagnoses that are coming to mind and what are we ruling out? So if you can, pull out your phones and just put in the chat as many different differentials as you can. Fractures, like anything that comes to mind. Could this be all the different things that we thought about today? So let's say it's in the ankle right now. Okay. RA, OA, love it. What else? Anything else? Just what's on your differential. Doesn't mean that that's what your diagnosis is. It's just the things that are coming to mind that you're going to work through. All right. That's how we build our differential. Anybody else? Any other? I'm going to put, I'm not going to participate, but get your phones out real quick here. Anything else? RA, OA, what else is on your differential, you guys? What else are you thinking about? Okay, I'm gonna keep moving just because for the sake of time. Oh, somebody's typing. I'll give you a second to type here. Anything in your differential with this guy? All right. And then what are some diagnostics that you might order? What would you consider ordering? Any ideas? Trauma. Okay, I like it. Yep, exactly. Asking these questions. These are the questions we're asking. We're thinking of our differential. What could be happening to this ankle? I'm thinking about my differential before I even walk in the room. All right. Like if I know ankle pain, I'm thinking through what could it be? What are the questions I'm going to ask? And based on what he answers, that's going to change the next question, right? And so you're just kind of going through this and building this up. All right, so some diagnostics I would consider ordering. Let's just pull over here. All right, so differential diagnosis. I'm thinking gout, osteoarthritis, rheumatoid arthritis, cellulitis, osteomyelitis, acute. We think of knee or ankle sprains, tendonitis. There's probably more. This is not, this is just some things I came up with as a differential diagnosis for ankle pain. And then diagnostics. So I'm going to consider ordering some labs, maybe an X-ray, maybe an ultrasound, maybe a joint aspiration. And for labs, maybe a uric acid level. So this guy's got He had some redness, swelling to the joint, and it's happened kind of on and off throughout the year. Maybe we asked him, he was at a barbecue and had some beers right before this next flare up. All right, so that kind of tells us let's order a uric acid level, ESR, white blood cell count, and then these are our results. So we did a joint aspiration. Actually, our rheumatologist who was down the hall. Okay, my community health center that I first worked at, we actually did have a rheumatologist that worked on site, and it was so helpful because we could often get the patient over there same day. So nice. And we had an x-ray machine, so nice. And we had a lab, so nice. We could get all of these results same day. Currently, that's not the place that I work in. So it's kind of like we take a little bit more time. We get their labs, get their x-rays, but they have to go, they get their labs drawn right in house, but they have to go get their x-rays outside. Here we see a little bit of mild joint degeneration, some swelling, but that's it. Their ESR is elevated, white blood cell counts a little bit high, and that uric acid's up to 11. All right, so now we're thinking for sure we know it's gout. All right, so what do we do about it? So we have these pre-treatment evaluations. So these are some rules. You can find this on Up to Date if you are, and it tells us the probability of gout. So we have low, intermediate, or high scoring. Okay, so you can ask these questions and what you're seeing if you can't get in there. So if male sex, you have 2 points, previous report of arthritic flare, that's another 2 points right there. You're at an intermediate risk for gout. And then if you have redness, okay, now we're at 5. Let's say it's in the first metatarsal, that's your big toe. Okay, it wasn't for him. He has hypertension, yep, so that's 1.5. Now we're getting into a little bit higher. And we lived and worked in a place that got us a uric acid level same day, and it's greater than 5.88. Now we're at 3.5. We're above. We have a high probability of gout, so we can pretty much think that that's what it is. So in this case, here's our treatment plan. We can do um, choose one of these, okay? We don't have to, we're not going to do all of them. Can we just get away with some indomethacin or oral colchicine? If they are seeing a rheumatologist, they may consider doing an injection in that area or systemic glucocorticoids, and then review that med list. Again, hydrochlorothiazide was on his med list. Is that causing it? Can we switch him over to like an amlodipine with his lisinopril to get him off of that? And that's in fact what I did with this patient. I got him off the HCTZ. He has had so many flares despite our best efforts. I went ahead and started after his flare kind of wrapped up with the colchicine, I added allopurinol. Now he's on allopurinol. We got him to max dose slowly. Okay, we were checking his levels every 2 to 4 weeks. As we were titrating up that allopurinol, we started at 100, we went to 200, we went to 300 milligrams, and we did finally get him to about a 4.5 uric acid level. He remains on the colchicine and the allopurinol at this time, and we will slowly take him off the colchicine. But you don't want to start allopurinol without colchicine. You're going to do both of those together because the risk of flare when you start the uric acid lowering therapy, the allopurinol, you may see more flares during that little bit. So you're going to go ahead and continually be treating with that colchicine and then continue the allopurinol long term and slowly come off that colchicine and make sure that you can prevent. All right, you can refer these patients out to rheumatology if you can't get it under control or if you have a concern in your ability to diagnose and treat this. Supportive measures would be limiting pain-provoking activities, intermittent application of ice, brace splinting as needed. All right, guys, that wraps it up for today. It was so nice to meet you. On that Slido app, just really, really quickly, if you look at kind of the hamburger up in the left top corner, this is just a direct link to our Facebook groups and our links. So if you aren't already a part of that stuff, go ahead and just add yourself to those groups. Lovely talking with you all today. I hope today's lecture was helpful, useful. You're going to do great, and I will see you all next week for respiratory. All right, take care. Have a good day.